Thank you for joining us tonight. This is a journal club for pediatric orthopedic trauma. The moderators are myself. I'm Keith Baldwin from Children's Hospital of Philadelphia. We have Ryan Kohler from Omaha, Nebraska, and Grant Hogue from Boston Children's. Our guest lecturers and authors are Alexander Arcater from Children's Hospital of Philadelphia, John Cheneker from Vanderbilt, and Ben Shore from Boston Children's. We have no conflicts of interest relative to the CME event. The larger AO organization has no financial relationships to disclose relative to this particular journal club, but we acknowledge funding for educational activities through the AO Foundation. AO North America is an independent, non-for-profit specialty society dedicated to the improvement of patients with musculoskeletal injuries and does not endorse, promote the use of any product, service, or commercial entities. Equipment used in this course is for demonstration and teaching purposes with the intent to enhance the learning experience. For this webinar, all microphones have been muted and video cameras turned off. Send in all questions and technical issues through the Q&A box. The moderator will review and sort questions as they appear and present to the faculty speaker. Use of the chat box is only for faculty and staff. So in terms of our agenda, there are going to be 3 articles, with the video 1 being management of pediatric type 1 open fractures in the emergency department versus the operating room, a multi-center perspective. At 8:20, there's video 2, which is the internal rotation stress test for supracondylar humerus fractures, which reduces cross-pinning and improves outcome in displaced pediatric supracondylar humerus fractures. And then video 3 at 8:35 is acute compartment syndrome in children and teenagers with tibial shaft fractures, incidence and multivariable risk factors. Then there'll be questions and discussion, and then we'll wrap up and adjourn at 9:10 to 9:15. So in terms of our learning objectives, at the end of the session or presentation, you will be able to describe an internal rotation stress test for supracondylar humerus fractures and when it might be appropriate to assess construct stability after pinning. Understand pediatric compartment syndrome and how it differs from adults in presentation and management and prognosis. Explain the proposed advantages of management of type 1 open fractures in children in the ED versus OR and potential downsides of each management strategy. And with that, we'd like to play the videos. So thank you for your attention. I'm here with Dr. Alexander Arcater. He is a very well-known trauma and tumor pediatric surgeon. He's well-known both nationally and internationally in both these areas. He is author of a multi-center paper called Management of Pediatric Type 1 Open Fractures in the Emergency Department or Operating Room, a multi-center perspective. It was published in the Journal of Pediatric Orthopedics in August of 2019. And Dr. Arcater is here to tell us about that paper today. So I had some questions about the paper just in terms of like, it's a very interesting paper. I mean, open fractures, in the past were like extremely, bad actors, like, they resulted in gangrene and amputation and stuff like that. And now, they seem to be a lot less like, I guess, bad would be the word for it. And I just wanted your take, having written this article in terms of pediatrics, like, why is that the case?
Yeah, I think that our understanding for open fractures has evolved quite a bit. When I started this paper, I was still practicing at Children's LA, USC. And as you guys are aware, USC, Dr. Patsakis was one of the main guys that did this push in regards to studying open fractures. And is that we learned a lot that how important it is antibiotics, and maybe how washing out and timing it's secondary to that. So there's a lot of things that evolved over time in relationship to open fractures. The other thing, direct to your question, Keith, is that I don't think that's just saying a grade 1 open fracture tells the whole story, right? So I think that there are open fractures in different situations with different intensities, in different bones. And those need to be seen separately. We just tend to group everything as an open fracture and treat it in a similar way. And it's probably a disservice to the patients.
Yeah, I totally agree with that. And like, it's definitely come a long way since Friedrich's original paper in the 1800s about open fractures and the 6-hour rule. So when you guys went to do this, there was clearly like sort of this dichotomy in terms of how people thought about these. Like there are some people still to this day where every open fracture goes to the operating room for debridement. Most of them get fixed, and that's kind of like the dogma that we all still kind of ascribe to. But then there's this more current, I think, maybe West Coast thinking that's more like that maybe they don't all need to go to the operating room. And so you guys had 4 centers. Like, what would you say, like the 4 centers, like in terms of their, like what were the 4 centers, and what's like the philosophy, like, would you say, in terms of like
I mean, for full disclosure, Keith's in my office is 10 foot apart. So our practice now, it's very similar, but the first half of my career was in the West Coast. And, I can't say that there wasn't a little bit of bias in deciding to do this paper, because our feeling was that, you look at West Coast, a lot of the middle of the country, people are successfully treating grade 1 open fractures without surgery. And you get the traditional East Coast institutions, and God forbid you don't take a grade 1 fracture to the hospital. So I think was kind of a family and friends appeal to this. A lot of the co-authors were former fellows or colleagues that we discussed in meetings about the subject, and they felt in a similar way. And we figured to build upon the 2 original articles on kids grade 1 open fracture upper extremity that were very positive results, but with very small numbers, and were single institution. So our idea was, okay, let's get more institutions, open the geography, right, of the area in the map that we're including, and see what we find. And that's what we did, knowing that it's still not the perfect study because it was retrospective, but also aware of the ongoing prospective similar study that was being done by the University of Chicago.
Yeah, and I think one of the interesting things that I found with the paper is that just in terms of our own practice, like you said, we tend to like wash out all of these, and thinking about it, although the in this paper it had a 2% infection rate in the non-operative group, that was because of like 1 patient, and there were none in the operative group. But I mean, it's like, it almost seems like the event rate is super low. So it's kind of like, what is your number needed to treat, and how do you sort out, like, how did you guys, I mean, it sounds quite logical, right? Like that you'd need more patients, but how did you guys like sort of figure that out? Like, what did you guys think would be like kind of like an optimal number of patients to have? Like, I mean, obviously more is better, but
Yeah. I mean,
in terms of what would be a valuable, like, like what would somebody care about? Like, it was like a 0.6 versus 0.5. Like if you had 1,000 patients, like.
Yeah, every time we bring this conversation in our pediatric meeting, there's somebody that will stand up and say, well, I had this open fracture, it was a grade 1 and had gangrene and lost the arm and patient died, or whatever it was. So obviously, 1 bad result is too many. I'm no statistician. You are. You tell me what the end to treat is. But I think that more important than the number, it's understanding the animal, right? We're talking about grade 1, like the little poke hole open fractures. We talk about those fractures that if they weren't open, they would successfully be treated in a cast, right? So those fractures, do we need to go to the OR, right? So that's the first point. The second point of the paper that you can see, is that we didn't really agree on how to give antibiotics or for how long. And I think that's the same in the adult literature. So I think there is a little bit of a personal experience and bias on it. Do you give IV? Do you give oral? Do you give one dose and send it out from the ED? Do you admit overnight? And I think this is a great point for discussion for the bigger group. What would be something that people will be comfortable with? But the point was, okay, not every single fracture needs to be taken to the OR because it's open. If you need to put elastic nails or plates and screws, sure, you're there, you might as well wash it out. So I think that that's really what we learned from it in this paper. But again, if it was 1,000 patients, maybe the numbers would be a little bit different. But like I said, one patient had an infection. Many more had complications from the surgery, by the way.
Right, yeah, and that's the other thing. Like it's hard to know with these, like, what do you think is an appropriate number needed to treat on these? Because I think the fact that you have like 200 patients and it's like infection's almost like not even a thing, for these type 1s. I think one thing that is like definitely that we definitely struggle with a little bit is like, who's seeing these patients, right? Like, so a lot of times, if we say they need to go to the operating room, they get seen almost like at a higher level of, kind of acuity almost. Like, if they're like in a tertiary referral center and you say, oh, they're open, they need to go to the OR, then they come to you and they get evaluated. So, because like what they might think is a type 1, like you might think is a type 2 or a really contaminated type 3, with a lot of soft tissue stripping. So it's just, I don't know, it's one of those things. It's a little bit, if you have good people that are looking at these, I think in a controlled environment, type 1s based on this data can be probably, at least considered for emergency room primarily care.
I agree. It's I've had residents call and say, I have a femur fracture. There's a little poke hole is a type 1 in a femur fracture, right? So we know that what's inside and not what's outside. So I think that to create some level of comfort in treating those conservative, my advice would be start with the poke holes, the ones that you squeeze in the skin because you don't know if it's open or not. Focus on upper extremity because the tendency is that they're probably cleaner or lower energy. And I personally think that admitting for IV antibiotics 24 hours, it's a good plan. Again, we didn't necessarily agree on that, but I still like 24 hours of IV antibiotics after opening or taking to the OR one of those patients. So you create your routine, who you're working with, if you're an academic institution or not. And then I think you're over time, you see, okay, those can easily be treated conservative. I mean, it's somewhat conservative. You stay in the hospital, I guess, but without surgery and the cost of surgery and the risks associated with the surgical procedure itself.
Right, and that would be like a kind of a compromised position. Like you get IV antibiotics, and you get a washout. It just wouldn't be like, formal OR debridement.
Yeah, and so I always ask people, I mean, what do you mean by grade 1 open debridement? Do you expose both ends of the bone and retract the periosteum? I mean, that's an opening debridement. Or do you just blast it and pray a little bit over the limb in the OR? I mean, that you can do in the ED just as well.
Absolutely. All right. Well, I would like to thank Dr. Arcata for his time and for participating in this journal club. Thank you.
Hi, I'm Ryan Keeler from Children's Hospital Medical Center in Omaha, and today talking with a good friend, John Schenecker from Monroe Carroll Children's Hospital at Vanderbilt. Today we're going to be talking about a 2001 pediatric trauma article that he co-authored titled Internal Rotation Stress Test Reduces Cross-Pinning and Improves Outcomes in Displaced Pediatric Supracondylar Humerus Fractures. And this is coming out of JBJS Open Access Journal. First of all, John, good to see you.
Always great to see you, Ryan.
So as you know, I was a resident at Vanderbilt while this paper was going on. So I'm pretty familiar with the internal rotation stress exam, as I think this was just getting started and you guys were incorporating this into practice. But I've always wondered, what was your motivation for studying this, or how did you guys come across this idea?
Perfect. So there was an article that came out of, I know some of the authors from Australia, I'd have to go back and see which one it was, that we discussed at a journal club. And what it came down to in terms of the internal rotational stress test, it is asked the question is, when is your fixation of a supracondylar humerus fracture in the operating room sufficient biomechanically? And one of the big points that the paper had made is that most of the data on supracondylar humerus fractures and biomechanical fixation are off of saw bones or cadaver bones that don't have periosteum. And they were the first that really breached, I think, that important idea that were our principles of what we do in pediatric orthopedic trauma is to identify where the periosteum's torn, figure out what could be hurt because the periosteum's torn, use the periosteum that's intact to reduce it, and then ultimately our fixation is to replace the torn periosteum. And that was one of the big things that we all thought in our group was missing from many of the biomechanical studies in supracondylars. So with that, it was around 2011, 2012 that we started talking about it more in our pre and post-operative conferences. And we all decided to start testing with the, not just the internal rotational stress test, but all stress tests. But we really focused on that in terms of stability of the medial column with internal rotational stress. And from there is where we moved into doing this. And that was really the impetus, is that it's hard to tell off of a sawbones if a pin construct is good or not because of that.
How I guess has this changed your understanding of reductions for the fractures too? Because I imagine, you know, you're talking about the periosteum and how it's intact and you're replacing it, but has this idea in doing this project, has it changed your understanding of how to reduce these fractures?
Very much so. You know, when we started off doing this and so many people get going, it's frustrating with supracondylars because you really think biplanar, you know, when you first look at these and you think, oh, all I have to do is flex this up. I see you laughing. You know that all too well. It's a, when you get out in your practice, I'm sure you get that humbling experience almost immediately of a type 3 just kicking your butt.
I think I have called you or texted you about a few of those occurrences, but yes, totally agree.
It's amazing. And from the biplanar aspect of it, we talk about extension type and we talk about flexion type. And so simply put, extension type, anterior periosteum is torn. And so flexing it using the posterior periosteum should lock it in. Flexion type, usually your posterior periosteum's torn and anterior periosteum's intact, and so you can extend it and it'll lock it in. But really the Wilkins modification of the Gartland classification system was that these are rotational injuries, the type 3s, and they're not biplanar. You have to think of them in a, you know, triplane type situation, and that usually what happens is on a 3A or a, what we all like to say is a posterior medial, is that the periosteum tears anteriorly and around the lateral side, and that the medial periosteum and posterior periosteum are intact. Whereas a 3B, or the dreaded posterior lateral, anterior periosteum's torn and the medial periosteum's torn, and that's why the fracture goes posterior lateral. Well, thinking of that, as you're reducing it, you have to think about using the periosteum that's intact to reduce it. And that can be, you know, a rotational reduction. A lot of times we'll use more of, you know, pull it out to length and use the periosteum that's intact, either medially or laterally, to push it over and lock it in, then flex it up. But in terms of reduction, I think that as we started all playing around with this, what we realized is how unbelievably unstable a posterior lateral or a 3B is in internal rotation.
Mhm.
And that really is, I think, the crux of all of this is that that's the hardest fracture to stabilize. And I'm sure you've probably experienced that.
Yeah, definitely, definitely. So, when you guys do this, can you just kind of maybe take folks through what your kind of quick setup is for doing this, and how you're using this technique on say a 3B?
Perfect. So the 3B is by far the best one to go to. And as 3B is a posterior lateral. And again, you can assess that by seeing usually there's a bruise over on the anterior medial aspect. Those are the ones that have a vascular problem or a median nerve injury. And typically what we end up doing with those is getting set up so that we can pull them out to length. You want to use that lateral periosteum. So as you flex up to about 30 degrees, this is to pinch it over, meaning going and pitching the lateral side over to reduce it, holding it in that position, using that posterior periosteum, lateral periosteum, and flexing it up. We then, the majority of us now will put one pin up the lateral column, and that what that does is gives you a good locking in of that lateral periosteum, lateral column. And then what we do is try to use a lateral pin to get across to stabilize the medial column. And so it'll be more of a valgus pin, if you will, that goes across the olecranon fossa to stabilize the medial column where that periosteum is torn. Once we've done that, we test the sufficiency of that by first going into extension on a lateral and making sure that that's holding the extension type of it. But then you internally rotate, stress it. And when you do that, that medial column, if it's not stabilized, will just pop right off. And the reason why that's important is that the best way to get cubitus varus is to have that come across and it collapse. And that's what gives you your cubitus varus. So if that is unstable with internal rotation, then we would either add a third pin, replace that second pin that goes across, or for many of us, that's an indication to go on to medial pinning.
Gotcha. So we've talked a lot about supracondylars, but we haven't kind of talked a lot about the paper, I guess, itself. I mean, a lot of these concepts are kind of throughout the paper as you go through it and read it. What in your mind are the key findings that you guys had from this study?
We were in a unique position, as you know, Ryan, is that we medial pin a lot. And because before when I did my residency here, looking back at it, almost every type 2 got cross-pinned. Greg Metzio and Neil Green just cross-pinned everything. And as there was data coming out about the potential of ulnar nerve injury from cross-pinning, they backed off a little bit, but it was still pretty much their standard of practice. What's nice about that is because we were all cross-pinning so much, we actually used the internal rotational stress to determine if we needed to cross-pin. And it was a unique setup. There would be very few centers that would be able to ask that question. Because we went into it with most of us cross-pinning type 3s. And so instead, what we started doing is all of us would do lateral pins and only do a cross-pinning if we found that it failed on an internal rotational stress. And what we found in the papers is we dropped from about 50% of cross-pinning down to, I think it was like 20 or 30%. It was incredible. Then the other thing that we found is that by testing this intraoperatively with that internal rotational stress, our loss of fixation went to 0. Is that, we knew that we were biomechanically sufficient with what we had. And that's probably one of the biggest things I found is that I think you have to ask yourself before you leave the OR, is this biomechanically sufficient to hold this fracture? So the two takeaways is because we went into this cross-pinning everything in the first place, we actually think that of the type 3s is you probably have about a third of them that with internal rotational stress probably do need a cross-pin if that's what your outcome is you're looking for. And that by doing internal rotational stress and other stress maneuvers I think you can really avoid that loss of fixation afterwards.
Hi, I am Grant Hogue, orthopedic surgeon at the Boston Children's Hospital. And we are here to discuss the paper Acute Compartment Syndrome in Children and Teenagers with Tibial Shaft Fractures, Incidence and Multivariable Risk Factors. This was published in the Journal of Orthopedic Trauma in 2013. And here to discuss the paper with us is Dr. Benjamin Shore.
Thanks, Grant. It's great to be here. My name is Ben Shore. I'm a pediatric orthopedic surgeon at Boston Children's Hospital. I specialize primarily in neuromuscular, lower extremity orthopedics and pediatric trauma, and it's great to be here.
So, Dr. Shore, maybe we could start by you just describing the impetus for this project, why you decided that it was worth, what seems to be a fairly large undertaking.
Yeah, it's a great question. And it's funny, I think this is probably apropos to many of the residents and fellows that kind of listen to these interviews. I didn't really know what I wanted to do, even when I was in my fellowship from a research perspective, but I was doing two fellowships. So I did a fellowship in Australia, and then I came to Boston and did a second fellowship. And in the first month when I was in Boston, I had a patient who was a teenage boy who suffered a tibial shaft fracture that went on to develop compartment syndrome. And similarly, when I was in Australia in Melbourne, I had a similar scenario where I had a patient who was a similar age, almost identical clinical presentation, had a tibial shaft fracture, developed compartment syndrome. And, for me, I had done 5 years of training and really hadn't seen very much of this, and then gone to two very different fellowships and had seen it in a relatively short time period at both institutions. And so it made me wonder, is this a real common thing, or was this just a really rare occurrence? And so that was that stimulated the thought process behind doing the paper. So, I think for students and trainees, you see these interesting cases during your training, and you should put them in your back pocket and think about why they happened and ask questions about them.
Excellent. And so when I read this paper, I think one of the real strengths, other than the fact that you've got really solid numbers, but one of the strengths of this paper is the methodology. So you used your univariate analysis to really determine the build out of your multivariable predictors. And one of the first papers that I saw do that was when Dr. Coker did that for the Coker criteria. And you've done something actually a little bit similar here. So can you talk a little bit more about how you built out your multivariable predictors in the process of determining those factors?
Yeah, so I think that in general, this isn't necessarily particularly interesting for most of the general readers, but from a stats perspective, when you do univariate and multivariate analysis, you're limited by the number of events you're looking at. So fortunately, in our sample size, we had 216 tibial shaft fractures and 25 compartment syndrome cases. And so some people will say that for each variable you want to study in a univariate analysis, at least for a broad univariate analysis, you need to have at least 4 events per one variable. So if you have 25 events, you can probably look at about 8 variables relatively without, you're kind of close, you're just over the limit. And so that's kind of where we drew our 8 variable limit. And then you do a univariable analysis and you look at the strongly predictive variables within that helps drive your multivariable analysis. And for the multivariable analysis, we just wanted to be a little bit stronger. And so we used only 4 variables, which is 4 times 8, which is around the similar number of 32, kind of right around our cutoff. So that's kind of how we did it. And we just kind of looked initially for the univariable analysis at the most clinical relevant features. And what was interesting in the multivariable analysis is that age and mechanism of injury, and in particular motor vehicle accident, were really significant predictors. So if you're over 14 years of age, your risk of compartment syndrome was 23% compared to 3% in the opposite element of the cohort. And similarly, if you're involved in a motor vehicle accident, your risk of compartment syndrome was 23% compared to 8%. So those were pretty strongly significant. And that's kind of, I think, the meat and potatoes or the takeaway messages from this paper.
Yeah, and so you've started to allude to your results a little bit here, certainly some of the more striking results. And so for you, based on that, how did you change your practice at the time? And potentially, how should the rest of us change our practice once we've read this paper?
So I think it's a good question, and by no means am I an expert, but one of the things when we structured this paper that I think is really helpful is trying to really characterize mechanism of injury, because I think it can be quite broad and not very helpful. So we really clumped all of the high-speed motor vehicle type collisions into one classification called motor vehicle accident. So that was on a motorbike, in a car, pedestrian hit by a car, ATV, any kind of powered vehicle fit into the motor vehicle collision group. And then we had a sports related group, because a lot of kids at this age play sports and suffer tibial shaft fractures from that. And then we had a fall greater than 6 feet and an other. And when we characterized them according to that mechanism of injury, it was really quite striking. And I'm just like looking at some of the numbers when I'm talking to you guys. But if you look at table 2 here, really, if you're over basically 14 years of age and you are and you suffer a motor vehicle collision, your probability of developing a compartment syndrome after a tibial shaft fracture oscillates between 20 and 83%, which is like really significant. Comparatively, in the other age group, it's from 0.5 to 3% in the same cohort time. And so, for me, what helps me is it really just helps me identify who are those high-risk patients. So kids that are over 14 in a high-energy trauma, my spidey senses are tingling. And I think it's probably related to some of the studies that have been demonstrated by Court Brown, which showed really that young males have inelastic fascia. Their ability to tolerate swelling is much less, and the risk of compartment syndrome is greater. And so I think those are like the real takeaway messages, is who to be aware of, who to be scared about. And then hidden somewhere in kind of in the fine print here is that the fact that in pediatric compartment syndrome, 10% of kids will not present with pain out of proportion. And they are presenting with normal, straight up compartment syndrome, but they'll present in different ways. And so it just makes you be extra cautious and aware of these clinical scenarios, and to really have your spidey senses tingling if you think that something looks not right.
No, I think that's fantastic. And so one last question. Within your group, you had a number of patients who didn't require surgery, who were just a closed reduction and a cast, but then still went on to develop compartment syndrome. And so for me, when you talk about your spidey senses or people who you're worried about, there are a lot of patients in that 14 and up group, even potentially high velocity patients, who could be treated in a cast, because that's the first line. And sometimes those patients will make their way out of the ER. And so how long are you holding these patients for observation in that group? Or are you doing 12 hours, 24 hours?
That's a great question. And what was interesting is that many of the kids that were treated initially with a closed reduction were kept overnight, and then because of their clinical scenario in the morning, were taken to the operating room. So there was only one case of compartment syndrome that was a closed reduction or a surgical intervention that went to the floor and then came back to the operating room for compartment syndrome. The majority of the cases were admitted overnight. So to answer your question, usually if you do a reduction during the day, you tuck them in overnight, you watch them carefully, and by the morning they're either good or they're not good. And if they're not good, waiting longer is probably not really the right move. It's just moving on it and doing some other sort of definitive treatment.
Excellent. So that's all I've got. We appreciate your answers, and this is an excellent paper.
Thanks, Grant. It's great to participate. I want to thank Keith and the rest of the AO for the opportunity, and happy to answer any other questions at this time.
So just in terms of reviewing these, had myself on mute there for a second. For the first paper was management of pediatric type 1 open fractures in the emergency department or operating room, multi-center perspective. Our author here today is Alexander Arcader. And some of the take-home messages were infection rate in type 1 pediatric open fractures is very low. This multi-center study suggested that type 1 open fractures in children can be considered for ED treatment. the number needed to treat is likely very high for to prevent one infection in terms of OR debridement for these fractures.
So, and maybe this is for everybody on the panel in regards to the first paper. Who is taking most of their type 1 upper extremity open fractures to the operating room still? Okay, we got most hands up that most of us are still taking these to the operating room. And maybe Alex, since you're the one who wrote this great paper, and maybe we should be following it more, what would your indication be to truly take a type 1 to the operating room versus one to leave in the ER? Is it one where you almost can't tell that it's open? I mean, like you were talking about pinholes, like where you're squeezing it to see if the blood's really coming out. Is that the one that I shouldn't take to the OR?
Yeah, it's a good question. I think that the first criteria is that you don't need to do surgery for the fracture itself, right? I mean, because if you need to fix the fracture, then discussion it's over. But I do think we're way too aggressive in taking those. They're like a tiny little poke hole, especially upper extremities, especially kids that are younger, 12 and younger. And that's what the other papers have shown too. I had one yesterday, and it was a tiny little poke hole, 11-year-old girl forearm, but the forearm was unstable. So I had to rod the forearm. So obviously then I opened and then did a formal washout. But I think if you start antibiotics pretty quickly, this is a fracture that happened in an urban area, a little tiny poke hole, upper extremity, young kids. I don't see a need to really go to the OR and do a big open surgery.
Yeah, I think the I'm going to try to not say this because I hate for Alex to hear that I agree with him. But I think, in this case, I agree with him. I think there's a couple of caveats, particularly in the Philadelphia area, which is like, number one, they oftentimes, and I'm sure, this happens at a lot, in Vanderbilt and Boston Children's, is like, when they get to you, you're like the second or third person they've been to. And usually what will end up happening is every person they go to will tell them that this is an open fracture, it needs surgery, it needs to go right now. And then, they get to you and you're like, yeah, it's not that bad. I'll do it the next day, or like, I won't do it at all. And like, I mean, it's just kind of, it's a difficult sell. And that doesn't mean that we shouldn't necessarily do it. But it also means that we have to be sure that nothing bad is going to happen. And like Alex said in the interview there, that there's always somebody who stands up at the podium and says, I had one of these that went really bad, whatever the case was. And I think that's kind of why it's still like dogma to do it. It's really hard to break dogma. But I think that papers like this, and hopefully the prospective paper that Alex was talking about, will help us start to do that. And then the other thing is, if you look at the original sort of Gustil and Anderson paper, and like how they classified it, it really was more of a soft tissue stripping off the bone, bony comminution type paper. And like everybody goes by the size of the wound, but it's really like the damage to the soft tissue that is what we're calling a type 1 versus a type 2. And I think sometimes it's difficult for someone with not as much experience to be able to tell what is a type 1 versus a type 2. I mean, it sounds like a very simple thing, but it can end up being more complex. So I got a bunch of hands up. So you want to go? Who I don't know who had it up first. Maybe Ben
I went first. I'm going first, John. You can
perfect.
just wait your turn.
All right,
But I think Keith and Alex, the point that both of you guys brought up is the crux of this, right? Is that generally, if you take a kid to the OR and wash out their fracture, they won't lose their arm, right? They won't. They can have a bad complication, but they won't lose their arm.
I disagree with that statement. I mean, you can have complications in the OR, you can lose your arm. I mean,
I don't think you can lose your arm from washing out a grade 1 open fracture and fixing it. I just don't think that's possible. Even if you
can get an infection, you can get an infection in your hardware. You can get compartment syndrome. You can get, all sorts of things. I mean, that's a little extreme a little on the extreme to say that, though.
Yeah, well, I think if you look at the papers that talk about complications of surgical fixation, of open forearm fractures, there's not very many that talk about loss of limb.
Well, in the
'Cause I've looked at
surgical
the
fixation,
literature.
is it really even a point? Because if you're operating on it and you decided it needs fixation, then you would wash it out anyway.
Right. So I guess my point that I was just trying to make is that the challenge here is that one loss of a limb is just such a great burden. And so it's really hard because we don't have the volume ever to get the number needed to treat unless we're in a war. Right? Like we just don't have that volume of open fractures to test it. I agree with you. And I agree with Keith that he's saying that the dogma is hard to change. But frankly, I think it is hard. I think in a small poke hole like you're talking about where it's rarely bleeding, it's probably a grade 1. But I think there's a lot of gray between grade 1 and grade 2. And especially I think using that additional distinction of upper versus lower extremity is helpful just because of the mechanism of injury for sure. I don't think there's a grade 1 femur fracture, right? I think we'd all would agree with that.
So just one question. So let me ask you this to all of you guys. Let's suppose you have a fracture, you go to the OR, it's a type 1 little poke hole. The fracture is stable in a cast, you don't need any fixation. Are you making a big open incision? Are you getting both ends of the bone exposing, making sure there's nothing in there, and then putting a cast on? Or what are you guys doing?
I mean, I fix them all.
I talk first, so I'll be quiet and let somebody else answer.
If I'm there, I fix them all.
I would agree with what Keith just said.
If you're in the OR, I fix it as well. And if you've washed it out and you have personally disrupted the periosteum, or if the patient disrupted the periosteum, then I would fix it.
Yeah.
All right, John, you had your hands up too.
Yeah, I think that a big part of this discussion has to be about the variable in terms of which variable is more important, and that is the surgery or the antibiotics also. And I think for the prospective study for this, it's very difficult. For example, here in the great state of Tennessee, for some reason, those open fractures tend to come in at about 11 o'clock at night. And, if our resident reduces them and talks to us about it, then if I send them home, those parents are probably not going to pick up those antibiotics at the pharmacy the next day if I wanted to give them 24 hours of antibiotics or more. Whereas if I keep them here overnight and I treat them the next day, they get their IV antibiotics. And I do think that variability is a really big part that makes this a very difficult thing to tease out, because I do think those antibiotics are an important aspect of this, as we figured out a long time ago. And so with that, Alex, if you get one of these and you send them home, are you sending them home on antibiotics?
Yeah, I don't send them home. And that was the what we didn't agree among different centers. I admit everyone for 24 hours of IV antibiotics.
For the exact
regardless of-
reason we were just talking about.
Yeah, even but not necessarily going to the OR.
Okay. So
Yeah.
I think that's probably, in terms of the prospective aspect of this, the only way we're going to tease this out is if everybody does what you do. And that is that you keep them around so that you can control the main variable. I mean, and that's the part that I'd say is that I think that you're almost, if you do it your way, Alex, I don't even know if you're asking the question if surgery is an issue, more or less, is it that the antibiotics take care of it.
I agree.
I'm going to put my hand down now.
That's perfect. You want to go to the next slide? I don't have any questions from the audience. I don't think I have like Q&A here. Nobody's asked a question. We're all very thorough. That's the issue. All right. So this is for I have this down as Article 2. So it's not necessarily Article 2, but I guess the thing is like, we're all PD pods and you can wind us up for, and we could talk about super collars for like 3 days. So it's probably good that we do the compartment syndrome next. So this one's acute compartment syndrome in children and teenagers with tibial shaft fractures, incidence and multivariable risk factors. So I just added on a couple of these ones just for people to generally consider. which is in pediatric orthopedics, you always want to consider 3 A's rather than 5 P's. The 3 A's being anxiety, agitation, and most importantly, increasing analgesic requirement, because those are the ones that are more linked to pediatric acute compartment syndrome. And then this particular study showed that patients 14 years and older with an MVA as their mechanism were at highest risk, and that vigilance and a high degree of suspicion are necessary, and early recognition is paramount. Okay. So now I have a couple questions about the previous study. So we'll rock those out real quick, and then we'll talk about this study. But so the first person says that the study needs to be done comparing just doing antibiotics versus going to the OR plus antibiotics to see if there's a difference. And I think that's what we were discussing previously, like in terms of like Alex's approach versus like, just a straight up ER plus PO antibiotics approach versus like OR and the whole shebang. And then the next question is oral antibiotics, if they can get them within 8 hours of their ER IV dose, sufficient? Is your center set up so that close reduction and sedation has to go to the OR anyway, or does that change your plan to always fix in the OR? So at CHOP, we have the ability to do sedation in the emergency department. Our residents are able to reduce fractures in the emergency department. How about Vandy? Is that the same thing?
Plenty of experience doing that in the ER.
Boston Children's? How about Omaha?
Yeah, for the most part in the ER, but we do some in like procedure rooms too.
Okay, so basically that's, that does not factor into our decision, but certainly if you were at a a smaller center, that might tip the scales a little bit, since the kids are already getting a sedation versus an anesthetic. I would like to ask, like, Ben, in terms of this compartment syndrome thing, like, did you guys find, I mean, maybe it's just I can't read or whatever, but did you guys find that transverse fractures were specifically problematic, or any particular like fracture morphology that you guys found were problematic?
Yeah, thanks, Keith, for the question. We used the AO classification. We didn't really find anything that drove that part of the model. So age and mechanism were really the #1 drivers here. And I think, when I talk to some of my colleagues in some other centers, they make fun of this paper sometimes because they think our numbers are really way too high. And I think the numbers may be higher than at other places, but if you look at one of the kind of landmark papers that I use was a study out of shock trauma that looked at their 7 attendings and looked at their rate of compartment syndrome across 7 attendings treating adult tibia fractures, and it oscillated between 3 and 23%. So the reality is there's going to be some surgeon factors involved in making the decision for compartment syndrome. But in this study, we didn't really think and find that the actual fracture morphology had a role per se in driving this, but it was more so age and mechanism more than anything else.
That's an interesting point, actually. So like, because a lot of times, most of these journal clubs, and in fact most of the material in AO is mostly adult material, but I find pediatric acute compartment syndrome is like its own thing completely, and the reason why I asked is because I found that most of my compartment syndromes have been transverse fractures, and like I even have one this weekend. And it was an MBA, but it wasn't over 14, but it was, it was a transverse fracture, and I saw it, and it was a little bit, I brought the fasciotome to the OR, and I was like, I'm just going to do it prophylactically. And I finished the nailing, and I was like, it's fine. I'm just going to leave it. Sure enough, she developed compartment syndrome like a few hours later. But my question is like, how does everybody on the call, like make the call for compartment syndrome? Do you guys use, like a striker needle, or do you just say, all right, that, or is it like kind of like and I know it when I see it kind of situation? Or how do you do it? Or do you go strictly by 3 A's?
So I go by clinical, and then also what I see in the operating room. I usually take a striker needle and just hook it up to an arterial line so that I have it on the field. And we'll just test the compartments as I go during the procedure and at the end and make the decision according to what I see with the direct measurements of those compartments and with the clinical exam I had before.
And so this is like when you're actually doing the case though, not like, so like if the kid's on the, like, suppose you already did the case and the kid's on the floor.
Yeah, clinical exam for sure. And the 3A's on that. I mean, I think that it's one of those things, like you said, I think when you see it, you know it. And you never, take out a couple cold appendices is okay.
Yeah, I think it's hard. Like I agree with everything that John said. And Keith, there's a question about explaining what a fasciotome is, but all I would say is that it's not always as straightforward, the clinical diagnosis. And I think you can have, I think it's not always so easy. So I think you have to look at everything together. So you look at kind of the non-standard kind of indicator. So, I think Dr. Hogan and I shared a patient who wasn't necessarily complaining of a lot of pain, but was like super hypertensive and super tachycardic. And when you said to him, "Are you having pain?" he wouldn't really say it's like the worst pain ever. He had some discomfort with stretch, but like his heart rate and his blood pressure were so high that the nurses were calling they were calling us not because of anything of his narcotic use, but just because how hypertensive he was. So I think you have to just use all of the kind of clues that you have around you, because kids may not understand what you're talking about and they may not be able to articulate the pain the way it's written in a textbook. I guess that's my only caution.
Yeah, and I would also say that, like, it can pop up when you don't expect it. Like I can still remember I had this like 7-year-old with like a proximal tibia fracture that was like non-displaced, and she was like off a wall with pain, and it was just like, her compartments didn't even feel that tight, and we were just like, this can't be compartment syndrome. This can't be compartment syndrome. And she was just had the 3A's, just like textbook 3A's. So I was like, all right, well, I guess she's going to the operating room. Took her to the operating room.
There's a good study that looks at how good we are at measuring how tight something is by our hands, terrible. Right? And it looked at like residents, fellows, and attendings. And there's no correlation with how tight something is and whether they have compartment syndrome, although everybody uses that, right? The residents like, they're like swollen, but not that compressible. It's like a completely useless data point.
Yeah. Yeah. And the point is, I did fasciotomies on her. She felt better in PACU. It was like, so it's one of these like really, so I think it's just one of these things where you got to always, with kids, they're not going to give it to you straight, basically. You just have to have a very, very high index of suspicion. And as John was saying, you're going to take out a few cold appendix. It's fine. You never want to miss one.
What clues do people use when they're rounding to kind of help guide them if a kid is comfortable or not comfortable, especially younger kids?
Bump into the bed test.
Yeah, I usually kick the bed.
Yeah, most kids should be playing a video game or watching a movie when you walk in, right? So that if they're not engaging in video games or movie when you walk in and they can't get comfortable in the bed, they've got compartment syndrome.
Yeah. Definitely.
John, you had your hand up before. Were you going to pepper me with a question?
I forgot to take it down.
It looks like there's a good question in the chat.
Yeah, I was actually going to talk about that part of it in terms of managing the wounds. I really like using that continuous measurement and, really trying to go off of basically a delta P in terms of the pressure and how the muscle looks as well. And once everything is released and you've confirmed it's released by taking measurements of all compartments, in terms of managing it, what I usually do is close as much as I can with the pressure monitor in, making absolutely certain that I don't go back into a compartment, and then put a wound vac on. And I usually come back about 2 days later and then take everything down, wash it out, measure the compartments, and then just work my way until I get it closed. And after about the third time, if I think that I'm not going to get it all the way, then I'll skin graft.
Yeah, so we wrote a paper on this that got published a couple years ago, just looking at our practice with management of fasciotomy wounds. And what we found is, like, the adult trauma guys across the street from us wrote that if you have a compartment syndrome after a tibial shaft fracture, after your first washout, if you can't close the skin, you should graft them. That's like the adult paper that's from the Brigham, which is on the other side of the bridge. So I just didn't think that was the case in kids. So we looked at our data, and what we found was that regardless of the number of washouts you had, your success of closure never decreased. So so the point is that you can be successful with closing a kid after fasciotomy 5 or 6 times, going back and doing like exactly what John talked about. And the success rate is about 50% with each washout. And it doesn't go down, and the risk of complications doesn't increase. And so I think that the message there is that you can continue to give at it and try. And in most situations, you will be successful if you are patient. I think people lose patience, or there are other factors that drive the decision to a graft. But I think that in most children, true children, you can get away with a closure.
Yeah, I've failed very seldom to close a kid, even after 2 to 3 times.
Yeah.
I mean, because you can use, we answer the question, we usually do 2 incisions. We usually close the medial incision on the first trip back, maybe do a couple stitches on the lateral incision, and then close the lateral incision with Donati Algowers the next time. Or, if you can't do it, you can bring them back a 3rd time, but usually you'll be able to do it after 3. All right, so just in the interest of time, we will go to our last paper, and there's a question regarding that, but I will just give a quick summary there. Internal rotation stress test reduces cross bending and improves outcomes in displaced pediatric supracondylar humerus fractures, by John Schenecker et al. And in this study, it was shown that the internal rotation stress test can help determine stability of supracondylar humerus fracture post-fixation. Use of internal rotation stress tests can reduce the incidence of medial pinning. And an internal rotation stress testing can reduce loss of reduction and reoperation rate. Okay, so we'll start with John here. Thank you. Regarding the steps for choosing a medial pin, again, in brief, during the reduction maneuver at operation.
Yeah, so in terms of a medial pin, I really think that the main 2 fractures you're going to need that for are the 3B, or the posterior lateral or flexion type, both of which typically have periosteal disruption on that medial column. And essentially what we do is get the lateral column stabilized with the reduction with the pin up it. And then you really want kind of a valgus, or if you're coming from the lateral side, valgus pin to get over to that medial column. And once you're there, you test, you stress in all positions, extension, external rotation. And then when you go into internal rotation, that's where you really pay attention to see if you get that sail sign, if the medial column just pops right off. And if it does pop off, that's where you decide, do I want to put a 3rd pin in, redo that lateral pin and see if you can grab that column. And if you're comfortable with putting medial pins in, I think that that's the indication for a medial pin is that the medial column has instability. And so I think that's just a nice algorithm for thinking through all the supracondylars.
Here's just like a technical question. So how exactly do you do your internal rotation stress test? Like,
Yeah,
I do mine. I grab the arm and just sort of like put it under floor, make sure I get a good lateral, and then move the forearm. But is that how you do it, or how do you do it?
No, what we do is we have everything out at 90 degrees, and we get an external rotation lateral first, and then we just put that on the other view, and then take it over and get an internal rotation. Usually have to lift up under the elbow or the shoulder to see it. And then all you're doing is looking to see that you get a matching lateral to the external rotation stress. And you can, sometimes you go to that internal rotation, you just feel it pop right off.
So Ben, how do you guys do your stress? Like, how do you stress your supracondylar construct at the end?
I don't do it a whole lot different than that. I just also do something in the coronal plane also.
Yeah. Yeah, we do that.
Alex, do you do what do you do for stress? for
Yeah,
supercondylar.
I've asked John to explain to me the test a few times before to try to understand. This is the best explanation you've ever given, John.
Thanks.
So good. I do life stress in the sagittal plane for the most part. I don't do a lot of stress in the coronal plane. In my experience, I mean, if the sagittal plane is pretty stable in those type 3s, I don't expect the coronal plane to be off. Am I wrong, Ben? Could you be just coronal plane kind of going back and forth, but the sagittal plane is perfect?
Yeah, no, I don't think you're wrong. I think you'll see what John is talking about, the medial spike. You'll sometimes see some coronal plane rotation when that spike kicks up, I think, because it's usually
Yeah.
not keyed in all the way, but I'll let him explain it.
And the other scenario is if you have comminution on one of the columns, then I think that you can pass on your rotational stress, but still be collapsing into cubitus varus or cubitus valgus if there's comminution on one of the columns, which is rare.
So generally speaking, your indication for a medial pin is like purely based on stress test.
Yes. So
like,
if
I mean, for extension type, and then that flexion type, forget flexion type for a second.
well, flexion type is the same. I mean, I think that you do your all 3 tests. It's not just the internal rotational stress, I think, is the best for determining if the medial column is stable. And that's why we focused on this. But I think that when you go to the operating room for anything in peds, you have to have some ability to ask the question, am I sufficient with the fixation that I have? And I think that's the part about supercondylars that's really helpful, to have a algorithm of asking that question. You know, there's the older saying is type 2s get 2 pins, type 3s get 3 pins. And I think that that's a good thing to start off with, but I think it's better to go to the OR and actually have a biomechanical test that you can say, I know that I have sufficient fixation.
I guess what I was trying to ask is like, are there any extension type supercondylars that you're going to medial pin off the bat, like from jump?
No, extension type, no. We've switched our practice now completely with that we'll go lateral pins first, and if it fails on the medial column, then we'll cross pin. And again, we're a group that used to, every one of them would get cross pinned.
Because I might be opening up a can of worms here with only 5 minutes left, but like, I think for me, like, I always tell our fellows is like the, if it's a high supercondylar, so above the fossa, if it's got medial comminution, or if it's got a high medial spike and you can't get that lateral pin beyond the 50-yard line in the distal fragment, and still get a medial pin, then I don't even bother. I just go straight to a medial pin from the.
I don't think that you're opening up a can of. I would agree with that. The metadiaphyseal junction supercondylars, the high ones. I mean, there's good stuff coming out on that. A lot of times those 3 pins and cross pin are the most stable construct. And then if you have comminution on it, you have to judge the comminution as to where to make it so it won't collapse in that coronal plane. And then obviously if you have a more oblique fracture that won't take lateral pins.
Do any of you guys feel differently about that? You guys are you guys using the 50-yard line thing, or are you guys, how do you guys judge to see if you're going to be able to get away with, or I should say be successful with, just 3 lateral pins in some of these variants?
And I think, Keith, I think that the principles described here are excellent. John explains really well the ones that he thinks they're going to be unstable already. I still try to put 3 perfect pins and then test it. And I think if I have 3 well-placed pins and still unstable, I'm not going for a 4th pin, that's for sure. I'm going medial pin. So as long as I can, I get both columns. So whether it's that 1 4/4 spin through the fossa and then a 2nd pin in the lateral column, if those 2 still not giving us enough stability, then I think you got to go medial.
Yeah, one other thing I just want to add to that, Alex was just saying is that, lateral pinning is the iatrogenic nerve rate of injury rate of lateral pins is not negative, is not zero. And, if you look at the meta-analyses, it's about listed at about 1% in the meta-analyses. And I think that where that's taken off is Peter Waters was the one who really highlighted to me about this is when people keep putting lateral pins in, eventually you're going to end up having some median nerve problems. And so I think that that's one of the bigger things is overall reduction of number of pins is an important thing to do. And as Alex just said, instead of just keep throwing more pins in on the lateral side is to have a reason for a different construct.
Here, so we only have like 2 minutes left, but I want to like burn the house down. So I failed to do it with the other one. So I'm going to try with this one. So how about this? Flexion type supracondylar with ulnar nerve injury.
Yeah.
One medial pin.
Yeah. It's the same thing, honestly, as is saying that we have a whole bunch of 3As that we have one lateral pin. If you know where that periosteum is torn and you go to replace it and it's stable, because that flexion type, don't you think most of the periosteum is torn posterior and medial?
Well, I mean,
especially if you have your ulnar nerve palsy.
Right. The reason why I asked is because every time I've opened, like, so when I see an ulnar nerve, palsy with a flexion type, like I open it immediately.
Yeah.
And I reduce it and pin it, and it seems pretty stable. I put a lateral pin just because, but I don't think it needs it.
Yeah, I agree with you. And I think that a lot of the 3As don't need more pins either. Same reason. Just don't go show that on your board. If anybody's listening to this, do not do that. And do not show that on your board.
Walk out of the OR with one pin. Don't do it.
Yeah, this is all just saying this is all just saying that if you understand it and you know when it's efficient, but don't put that on your boards.
Yeah, don't put it on your boards. But I think if the one thing with pediatric orthopedics that you really have to understand is the periosteum is your friend. And if you know where it is, that can guide your fixation, more than almost anything. So, and you really have to support the areas that have periosteum torn. And if you do that, then you'll have a stable construct. And I think that's the theory. It's kind of a little bit of a reductio ad absurdum comment, but because it's like you just can't. It's hard to leave the OR with one pin, and you should definitely not do it going to boards. But you should definitely know where the periosteum is and use it to your advantage because your patients will appreciate it. I'd like to thank all the panelists and all the moderators and all the participants for your time. And I'm gonna have you advance a couple more slides here. Our take-home messages are that type 1 pediatric open fractures have a low infection rate and time to antibiotics is most important. Number 2, 3As as opposed to 5Bs should be considered when assessing pediatric compartment syndrome. Teens over 14 who are in MVAs are at greater risk. And consider an internal rotation stress test to reduce the rate of medial pinning as well as loss of reduction in reoperation. Next slide. An upcoming journal club session to be announced for July 19th, 2022. Next slide. Thank you for your participation, and a link to the recording will be sent out through Zoom 24 hours after the conclusion of this session for those who registered. And it's on AO Trauma North America YouTube channel. Thank you for your participation. There'll be a short poll now.